2 in OBGYN in Miami Beach, Florida. Going to talk about acute NMDA receptor encephalitis causing psychosis in previously healthy young woman. Have you all heard of anti-NMDA receptor encephalitis? I got like 2 slides on it in med school. I don't remember UWorld testing me on it at all. Did you all hear about it before Netflix made a movie about it? Okay. So anti-NMDA receptor encephalitis, it's a limbic encephalitis, so it affects the immune system as well as the limbic system, the amygdala, hippocampus, so it affects mentation, it affects memory, it can also affect the hypothalamus, it can cause fevers and somnolence. It's associated with ovarian teratomas in 50% of women over the age of 18, and it can cause prodromal symptoms, including fever, headaches, vomiting, as well as psychosis afterward, which we'll get to. So we have a previously healthy 28-year-old female, no past medical history, has 5 days of headaches, vomiting, and just feeling unwell. She comes to the ED. They do a basic workup. They don't really find anything. They give her Tylenol. The headache and fever goes away. She did have fever, so they gave her Ceftonir and sent her home. They didn't really know what the problem was. They just gave her an antibiotic because she had the fevers. Comes back a few days later with worsening symptoms. The headache is more severe now, and she also has nuchal flexion pain. So they get a CT head. That's negative. They do a lumbar puncture. That workup is negative as well. They admit her overnight. They keep an eye on her. They diagnose her with presumed viral meningitis. They send her home with pain. She comes back a week later. She's confabulating. She has visual and auditory hallucinations. She's combative. She's a different person than she was a week ago. At this point, how many of you would image her reproductive organs? Show of hands. Thank you. That would have thrown off the flow of my presentation. How many of you would have imaged her reproductive organs at this point? Hallucinating, confabulating, nuchal pain with flexion. No one would image her reproductive organs, right? Right. So she is admitted overnight. Neuro and psychiatry are both asked to come take a look at her. She's combative. She's aggressive. She leads against medical advice before she can be seen. But she is referred to outpatient neurology a few days later. She goes to that neurology clinic, and by the time the neurologist gets into the room, she's unconscious, difficult to arouse. Immediately, she is sent back to our hospital. And he says in his consult note specifically, she needs to be worked up for acute NMDA receptor encephalitis. So you guys see my, can you see my mouse? No. Yeah. So in the middle of the screen, we have this diagnostic worsening. She gets ANA positive, suggesting that there is an autoimmune etiology to her symptoms. Anti-dsDNA antibodies are negative, suggesting it's not lupus. We get an anti-NMDA receptor IgG antibody. It's more specific than IgM. That is drawn from her CSF. The lumbar puncture workup is again negative, but this lab is sent to send-out lab. It takes usually a week or more to get back. So we're gonna have to wait a week to get this back. That is what we use to diagnose NMDA receptor encephalitis. Again, EEG, which shows cerebral dysfunction, but that's not specific for encephalitis. We also get an MRI of the brain, which is negative. We get a pelvic ultrasound right here. You can see my mouse, but they don't do that when she first gets here. That's gonna happen when she gets to the ICU. But for the first 5 days that she's in our hospital, we start treating her for anti-NMDA receptor encephalitis, the presumed diagnosis, with methylprednisolone. It's 1 gram daily through the IV for 5 days. She does not get better. Actually, she gets worse. And after 5 days, she's sent to the ICU, where we add IVIG therapy to her treatment. It's in the ICU, the intensivist finally orders ultrasound of her ovaries. And that's where we see what looks like could be a dermoid cyst or an ovarian teratoma. Gynonc is consulted, and they do an urgent laparoscopy, a salpingo oophorectomy. Was in the OR when we do this, he takes out this ovary, cuts it open. It's a classic teratoma. There's hairs, there are calcifications that look like teeth. And what you can't see, because they're microscopic, of course, are these antibodies to the NMDA receptor. And a few days later, we finally get back the result of the anti-NMDA receptor IgG antibody. It's positive. So that's how we diagnose this anti-NMDA receptor encephalitis. So I'm gonna kind of pass over the histopathology, but all layers of the embryo or embryonic layers were present in this teratoma. So point of this that I want to stress is that this needs to be on the differential for previously healthy young women that come in with prodromal symptoms that progress to encephalitic symptoms, altered mentation, and psychosis. So this woman, it's kind of very small script. I don't know if you can read this, but after her surgery, she needed to be intubated. She suffered an esophageal perforation causing pneumomediastinum, and respiratory failure. She had a DVT, She had recurrent seizures. She required a tracheostomy tube and had to get a jejunostomy for feedings. After she was discharged from the hospital after rehab 2 months later, they had to be readmitted for an enterocutaneous fistula. One went through hell. And she went to the ED 3 times. She also went to an urgent care clinic. I didn't include that because we didn't have records for that. No one diagnosed this, and it would have been difficult for them to do. Because when you have encephalitis, nuchal flexion pain, fevers, you're not thinking, let's check the reproductive organs. It wasn't until a neurologist recommended it and that the intensivist ordered imaging of ovaries that this was diagnosed. Right? It was a difficult diagnosis. If this had been diagnosed in one of the first 3 times she went to the ED, she wouldn't have had the DVT, fistula, the seizures, and everything she went through. I saw her in the outpatient clinic almost a year after her symptoms started. She was back to normal. She was working full time again. She was back to working on her master's degree. And she said she didn't remember most of it because it caused memory loss. She didn't remember. She remembered the first few weeks, the fevers and the headaches. She did not remember her altered behavior. She didn't remember the 2 months that she was in the hospital. This is a potentially fatal disease, and we need to keep it on our differential, even though it is a zebra. We're trained not to suspect zebras at first, but if they had this on the differential, it might have spared her all these complications. So, that was a lot. Any questions?
Currently experiencing
Any sequela? Nope. No, I saw her in the clinic. She was as good as new. I asked her, I said, you almost died. You realize that? She's like, yeah, that was wild, huh? She didn't even, it's like, she is grateful for the experience. She said she appreciated life more, but yeah, she has scars on her abdomen, but yeah, no sequelae other than that. It's been around for millennia, and it's actually hypothesized that women who had hysteria or melancholy in the past may have had anti-NMDA receptor encephalitis. It's exceedingly rare. And because it is so rare, it's tough to put a number on. I've seen anywhere between 1 in 20,000 women to 1 in 250,000 in the general population. More common in women of reproductive age. It's less common in younger females, and in younger females are less likely to have an ovarian teratoma. It's at less than 10%. Yeah, women 18 and older, there's a 50% incidence of unilateral or bilateral ovarian teratomas. But it is exceedingly rare. Why we didn't have a name for it before 2005. Yep, and also because she still has 1 ovary, there's a recurrence rate of 15 to 24%, based on several studies. It's when the incidence is rare, it's tough to get accurate numbers, but several studies pointed between 15 and 24% recurrence rate, particularly if you still have at least 1 ovary from which you can develop teratoma, which produces these antibodies. Only if she develops symptoms. We saw her once, we saw her twice in the gynonc office, because our role as OBGYNs in gynonc was she had the ovarian teratoma. So she came to our office and she asked, actually, do you need to check, do you need to follow up on my other ovary? I said, nope. Yeah. Having another thing that women of reproductive age want to know is, can I get pregnant again? I only have 1 ovary. Yeah. Usually your fertility rate is 80 to 90% compared to if you still had 2. But from the OB-GYN or gynonc perspective, no, and with neurology, only if she develops it. Now, if she starts developing nuchal pain with flexion, of course, she's gonna know what it is instead of having to go to the ED and urgent care several times. So it's gonna be more on your radar. But for follow-up, no, only if she develops it. She had no abdominal or pelvic pain. When she first presented, she had the headaches and fevers as well as non-bilious, non-bloody vomiting. But again, if someone comes into the ED and she doesn't have any abdominal pain, she doesn't have any vaginal bleeding or discharge, you're not going near the pelvis. And where we live, our hospital's in Miami Beach. We're 10 minutes drive from all the clubs on South Beach. If a 29-year-old comes in vomiting, at one point she did get a tox screen, but we see women coming from clubs more often for intoxication rather than a rare dermoid cyst causing bodies.
Yeah, last question.
On what? Yes, of course, they don't have ovarian teratomas, but it's less rare. So when we think acute anti-NMDA receptor encephalitis happens more often in women. but it's also, I mean, endometriosis has been documented in males as well. We don't know why.
Thank you.